So thank you, Dr. Sanjeev, for having me here. And the session is quite special to me as it has probably the most talented senior that I have come across and equally talented juniors. So I would be speaking on strabismus surgery under topical anesthesia, and seeing all the surgeries earlier, this should probably be the most painful considering the manipulation of the extraocular muscles that is involved in strabismus surgery. So about 3 to 4 years back, I was quite apprehensive about topical anesthesia, but gradually I've been doing strabismus surgery under topical anesthesia in a selected number of patients. So what is the situation in relation to strabismus surgery elsewhere? In the United States, most of the strabismus surgery is performed under general anesthesia for medical legal concerns related to analgesia and amnesia. In Singapore, it has been on for quite some time. There are plenty of reports, and gradually the acceptability is increasing elsewhere because there are some clear advantages which I discuss here. When we are doing adjustable surgeries, it allows adjustment on the table. You are able to ensure a diplopia-free primary gaze. And if the patient is under a block, this adjustment has to be done on the third bone. So a good number of patients of concomitant deviation or small angle deviations, we are able to perform the adjustment on the table with patients being under topical anesthesia. Similarly, when adjustable sutures are used, sometimes you have to titrate the correction, and this is also possible with greater ease under topical anesthesia. In bilateral surgeries, you don't want to patch both the eyes, so again, it has an advantage. And all the disadvantages of block go, such as chemosis and rise in the intraorbital pressure. It is obviously indicated in patients who are sensitive to xylocaine. Now, surgeons who have performed about 100 strabismus surgeries should be able to try this. And another criteria that I've added is that you need to be a reasonably experienced surgeon when you are upgrading to topical. For strabismus, it is about half an hour of surgical time for 2 muscle surgery. If you take longer, then probably you need to first polish your skills more before you upgrade. Regarding the patient, it should be a cooperative patient, preferably over 18 years of age, and should be willing to bear some pain. You can't promise a painless surgery, painless strabismus surgery when you are performing surgery under topical anesthesia. It should be limited to horizontal muscle surgeries and initially only recessions, because greater amount of manipulation is involved in resection surgery, which can be uncomfortable. And whenever you are performing adjustable or bilateral surgery, it has a clear advantage. With regards to modification and steps, preoperative use of xylocaine jelly and phenylephrine drops to reduce the vascularity. Intraoperatively, don't try the fornix incision. The paralimbal incision provides a wider exposure with minimal manipulation. Use xylocaine prior to hooking the muscle. There should be minimal manipulation. Pull on the muscle should be minimum. This you have to tell your assistant. Very often the muscles get pulled. So analgesia is ensured by xylocaine, but not the discomfort related to the pull on the muscle. Minimal cautery and preferably heat cautery, because heat cautery is less uncomfortable compared to the electrocautery. And using tissue glue for conjunctival closure not only minimizes your surgical time, but also reduces the discomfort associated with manipulation of conjunctiva. Do not pull. Minimize the electrocautery. You should be confident about identification of the muscle. You can't be fishing for the muscle in a patient who's under topical anesthesia. And an important point is that you have to connect the monitor because oculocardiac reflex is often exaggerated in the absence of block. So specifically when you are dealing with the medial rectus. So although the patient is under topical anesthesia, the monitor should be connected in all patients who are being operated for strabismus. Now this is a patient who underwent recession resection surgery for exotropia in the left eye, and I would be showing his video. Now these are the initial traction sutures, which we proceed as usual. We would be giving the modified von Nuden incision to ensure a wide exposure. This is the recession of the lateral rectus muscle, which is being shown initially. The muscle is hooked with minimal manipulation. Heat cautery has been used, and then the muscle is anchored onto the 6O vicral sutures. The muscle would now be disinserted and reattached at the recessed site. The conjunctiva is closed with fibrin glue. Now onto the resection. This is the medial rectus. One has to be extra careful while handling the medial rectus because firstly, the space is slightly lesser. It is more painful and there are greater chances of oculocardiac reflex. The muscle has been identified. Heat cautery would be done and the muscle anchored. The stump is now removed and the resected muscle sutured back onto the original insertion site. The middle suture is being given, and finally we reattach. The adhesions are severed, and we reattach the muscle, reattach the conjunctiva with fibrin glue. Now, this is a small video to show the immediate post-operative mobility. And this is finally the response of the patient. So the pain is tolerable. You can't promise a pain-free surgery. Now, another patient of traumatic cataract with sensory esotropia, he underwent a topical phacoemulsification followed by, the recession surgery is done first. So he underwent a medial rectus recession followed by topical phacoemulsification in the same sitting. So thank you for a patient hearing, and I'm open to questions should there be any.